the next session. Oh, louder. Oh, okay, we can do louder. Okay, Yati. Yeah, I'd like to invite you as our next presenter, and I think you've prepared 3 cases for the second case presentation. Have you?
Yeah. Yes.
Yes. Okay.
All right.
So just a bit of an introduction of our next speaker, Dr. Nur Hayati Yunus. She's actually my junior during masters, and she graduated from USM in 2004 and completed her masters of pathology from USM also in 2013. We sat for the FIAC exam together in 2019, and it was a most interesting, challenging experience, wasn't it, Yeti?
Yes.
Before and after the exam. And at the moment, Dr. Nur Hayati is an anatomic pathologist with special interest in cytopathology in Hospital Raja Perempuan Zainab II, Kota Baru, since 2013 until present day. So I pass the mic over to you, Yati, virtually.
Okay. Assalamualaikum warahmatullahi
Yati,
wabarakatuh.
don't
Hello?
forget to like use the presenter's version. Can you just click that little thing at the bottom there and speak loudly?
Presenters.
Yes, this one. Okay, you're good.
Okay. I just only I can see only my slides. I cannot see others. Okay. Assalamualaikum warahmatullahi wabarakatuh. Okay, so let's continue with next presentation because this is already afternoon. Everybody's already hungry, I think. Continue. Okay, proceed with case number 1. This case is patient is 55 years old, female. She presented with painless right thyroid swelling for 3 years. On clinical examination shows there is a thyroid mass measuring 5 by 4 centimeter. It was non-tender, firm to hard inconsistency, and it moved with swallowing. So they proceed with FNAC without any radiology ultrasound before. Okay, so this is the under low power view. So basically just to show the cellularity, very cellular. It's like a tissue fragments, okay, and looks like very cellular cell proliferation. And if you can see the pinkish materials as well as scattered mononuclear cells in the background. Okay. A bit under high power, you can see that this is pinkish materials, looks like more or less look like implicated colloid, and there's some follicular-like cells in the micro follicles, and the rest of the fragments shows proliferating and overlapping epithelial cells, and you can see at the edges is there is a pinkish material that is associated with the cells. Okay, this is the higher magnification at edges of the one of the cluster, few of the cluster. You can appreciate the cells quite round, some are oval, and you can see a very well defined pinkish materials within the lumen. So most of them like forming a micro follicles. What we can see is on they are forming like a micro follicles, and in fact this is the quite thick smears. What we can appreciate at the edges is more of microfollicular cells, and really hardly we can see any cytoplasm. And the background of pinkish materials, if you can appreciate in the background, is more or less like a bit, some here like looks like granular. So okay, I already mentioned all the all the information. So What are the differential diagnoses for this? So first, we think clinically is more of nodular thyroid lesion. So most based on the architecture, microfollicular, and the cellularity is a bit more than the colloid material. Top on the list is follicular neoplasia. How about medullary? Medullary thyroid carcinoma. Can it be the pinkish material? Can it be uh, what we call amyloid? Still possible. However, the cells like that previously mentioned by Prof. Sharifah just now, in medullary thyroid carcinoma, the microfollicle is not usually seen in the medullary, and furthermore, the cellular atypia, the morphology of the cells doesn't look like plasmacytoid like the usual medullary as presented by Dr. Mukarramah and Prof. Sharifah just now. So these are the possible differential diagnoses. So the other possibility, is it possible for the non-thyroid primary? Still possible, but it is down on the list because it is very rare. Okay, so the FNAC reported as follicular neoplasm and unable to rule out carcinoma, which is type 4, and we suggest for excision. So I already mentioned the features that why we put as a follicular neoplasm as our first diagnosis. Okay, so this is the HPE finding. You can see that the tumor is very close to the this is the normal, looks like normal thyroid, and is embedded within the thyroid, and this tumor also shows a very extensive lymphovascular invasion in the histology, but I just take a few example here. So what you can notice in the morphology, the appearance of the tumor, anybody can guess? I couldn't hear and I couldn't see anything. Okay, so this is the close-up view for this tumor morphology. So this shows very nice cribriform pattern of the tumor cells. And the cells morphology more or less like a bit basaloid in appearance. So the diagnosis was given is metastatic adenoid cystic carcinoma. So because clinically they're thinking more of thyroid primary as well as radiologically more of thyroid mass, thyroid primary. So during that time, probably the radiology report more didn't commit anything about the secondaries. Okay. So based on the HPE, we look back at the cases. We search for the possible what the pitfall or what that we miss up during that times. So we look back at the thick clusters just now. If you can appreciate at the some of the clusters shows a bit columnar and palisaded in appearance. So this is actually very difficult case because I think it's quite difficult to differentiate basaloid cell and follicular cell. But here at some areas, you can see palisading, nuclear palisading at the edges, as shown here. Okay, and these are the other areas. Okay, and the cell is a bit columnar at the edges, a bit oval and more of columnar rather than cuboidal. So this is the other view, the other areas that because the smears is very thick, and in fact we only have this one slides only, no pap stain, no cells in the pap stain. So we need to rely on this only one mgg marker, mgg stain only. So if you can appreciate, you can see that the cells looks like a bit palisaded at the edges. Okay, hardly we see any nuclear features of papillary thyroid carcinoma. Okay, the cell looks like more of uniform, monotonous in appearance. And apart from that, this is the areas that uh, also present in the smears. Okay, you can see that the cells, these cells um, is in sheets. You can see it is in monolayered sheets and is mononuclear. And these cells was initially described as follicular cells. So this is really mimicking of mimickers for the follicular cells. And if you can appreciate that this pinkish material is the metachromatic matrix spheres that was typically described as sharply defined borders, that this was described as bubblegum colloid, some bubblegum colloid appearance in the follicular thyroid carcinoma. So for this patient, intraoperatively we review the case note. I review the case note. They mentioned that the clinically they thinking of aggressive thyroid carcinoma with severe adhesion and severe infiltration into the trachea circumferentially. So 1 month after the operation, after the total thyroidectomy, they proceeded with CT, thorax, abdomen, and pelvis. So they noted that presence of multiple pleural base nodules. Hello? Sorry. Okay, there are presence of multiple pleural base nodule and increasing features of metastasis. So they think that this primary lesion could be from the trachea. So just a bit story about the adenoid cystic carcinoma arising from the major and minor salivary glands, and it is usually account less than 10% of all salivary gland tumor. And it is slow growing malignant tumors that might be aggressive with a high incidence of distant mets. And despite from the salivary glands, adenoid cystic also has been reported in other locations including breast, larynx, lung, and trachea. And the female predominance with peak incidence in the 4th to 6th decade of life. So direct invasion of the thyroid by malignant neoplasm from the laryngotracheal complex is very, very uncommon. However, it is well documented in the literature. And the vast majority of epithelial malignant neoplasm of the larynx and trachea are of squamous, usually more of squamous. However, non-squamous carcinoma is less than 1% of all carcinomas of the laryngotracheal complex. And adenoid cystic carcinoma is the most prevalent. And the spreading is usually by direct extension with perineural invasion and hematogenous metastasis. And lymphatic spread is uncommon, it was stated. However, in our case, there is multiple lymphovascular invasion seen. So the diagnosis of adenoid cystic carcinoma often is less problematic when the tumor is located in the salivary gland and when its characteristic appearance on the FNA cytology is seen. It's mentioned that hyaline globules in adenoid cystic might also be mistaken for amyloid in the aspirate of medullary carcinoma and thick colloid in the follicular carcinoma. And in fact, there is a few cases that was diagnosed as papillary carcinoma has been reported in the literature. The other differential for the non-thyroidal neoplasm with having features like hyaline globule-like material including pleomorphic adenoma, basal cell adenoma, epithelial myoepithelial carcinoma, polymorphous low-grade carcinoma, and skin appendageal tumors. So these are the differential that we need to think about when having this kind of cases. Okay, so this I would like to share one this article, a pitfall in the thyroid cytology. They reported a few cases of adenoid cystic with direct extension from the tracheal as well as laryngeal complex. So they are describing basically a few features that help us to differentiate between adenoid cystic with the other common primary thyroid neoplasm. But I think practically is really difficult for us. But basically, if you identify the pattern of the cells in reforming or trabeculae, so it's more helpful. And apart from that, they also differentiate that the nucleus of the adenoid cystic is oval to elongated as compared to the others of common primary thyroid neoplasm, where they are more of round to spindle and very irregular in anaplastic. So basically, like in our case, is more of oval to elongated is there, but without any nuclear features of PTC. But because of the rarity of the entity, so we might not thinking of it at the initial stage. Okay. Okay, so I proceed to the second case. Second case is 79 years old male presented with anterior neck swelling for 3 years duration. So this patient having on and off difficulty in breathing and associated with hoarseness of voice for 3 months duration, and he denied any constitutional symptom. Clinical examination shows the neck mass measures 10 by 8 centimeter, no cervical lymph node noted at that time. So in this case, they proceeded with CT scan straight away because this is the case from district hospital, showed that bilateral thyroid lobe are diffusely enlarged with presence of multiple hypodense nodule bilaterally and microcalcification within the right and inferior pole of the left lobe. The right lobe measures 4.4 by 3.7 and 8.2 centimeter, and the left lobe is 5 by 5.2 by 9.3 centimeter. And the trachea is displaced posteriorly and to the right side, with the trachea lumen slightly compressed. However, the clinical impression during that time is multinodular goiter with compressive symptom. So they proceed with FNEC. So this is the higher power view of these smears, very quite cellular, and what we can appreciate is quite bloody. Really difficult to identify any pinkish material or colloid in the background. And you can see that the cells architecture is more of dispersed. And some cells a bit larger, quite polymorphic and heterogeneous in some areas. Okay. Under a bit higher power, we can see that some of the cells forming like a microfollicles and a bit loosely cohesive cells, and a few cells here looks like some cells appears like histiocytic in appearance as well. So at these areas, more of loosely cohesive clusters, but more predominant cells are dispersed, single, and is more of mononuclear cells. And if you can appreciate in the background, there is, I think most of you knows it, there is lymphoglandular bodies. You can appreciate there's a lot of lymphoglandular bodies in the background. Okay. So under higher power, we close up view, those are atypical cells are seen. Quite large. How if you can see, the chromatin is a bit coarse, hardly any nucleoli, and some cells are very irregular nuclear outline. Okay. And this, I show you the normal lymphocyte that we can identify. The size of the cells, the atypical cell is a bit larger than the normal. It's very large comparing to the normal lymphocyte. This is normal lymphocyte because we can still see the cytoplasmic rimming at the edges. As compared to the other cells, the other atypical cells, hardly we can see any cytoplasm. Okay. So this is the other view, and here the cells a bit monomorphic with we can appreciate the background of lymphoglandular bodies, and hardly we can see any colloid in the background. Okay. This is the PEP stain. Okay, you can see that the cells quite monomorphic, not really not to say really large, but we can compare with the normal lymphocyte. I think this one possible normal lymphocyte, and you can see the nuclear features is a bit some shows a bit coarse chromatin. Okay, coarse chromatin. Hardly we can see any nucleoli. Okay. This is under higher magnification, just to show you this is possible. This is the atypical lymphoid cells, atypical cells likely to be lymphoid in origin because of the background of lymphoglandular bodies you can see in the background. And this is we compare with the normal size of the lymphocyte. It's almost about 3 to 5 size of the nuclear size of the normal lymphocyte. So it's large, but hardly we can, is not predominantly large. It's more of small to intermediate with occasional large cells. And some you can see the small cells having a nucleoli. So differential diagnosis for this case is definitely there is atypical cells, most likely lymphoid because of the background of lymphoglandular bodies we can appreciate in the background, and hardly we can see any colloid. And if of course lymphoma is one of the, we cannot really exclude lymphoma in this case. The other differential diagnosis that most usually people thinking of is lymphocytic thyroiditis. So this is, I think already presented very thoroughly by Prof. Sharifah just now. In lymphocytic thyroiditis, usually the population of cell is more polymorphic, and there is also presence of Hurter cells, and the atypia is not so prominent in the lymphocytic thyroiditis. However, is contradict with our case, the lymphoid cells, the atypia is too prominent in this case. Okay, so that's the differential diagnosis that we can give in this kind of case. So what is the FNAC reported as features consistent with the lymphocytic thyroiditis, with the comment of low-grade lymphoproliferative disorder cannot be excluded. So because of that, so they proceeded with ultrasound guided biopsy. So noted that there is a well-defined hypoechoic lesion at the lower pole of the left thyroid with intralesional vascularity seen. However, the biopsy was inconclusive due to severely crushed tissue. So we commented on that biopsy to proceed with incisional biopsy. So they proceed with left thyroid incisional biopsy. So this is the histomorphology of the biopsy. So the cell is, the tumor cell is really dispersingly, okay, dispersingly and very pleomorphic. Doesn't look like follicle forming a micro follicles, okay. It's more of diffuse sheets. And if you can appreciate some of the cells, the size of the cell is more of small to medium, with some cells are quite large, and with prominent nucleoli. Most of the cell having a cleave or irregular nuclear outline. Okay, and the chromatin is more coarse uh, in appearance. So we proceed with extensive immunohistochemical marker. The cell are diffusely CD20 positive with a high proliferative index proliferation of the tumor cells. And in fact, we also proceed with thyroglobulin, and it shows that a few residual thyroid follicles presence within the lesion. However, note that CD3 is also quite prominent in this case, and this case is quite difficult. And in fact, we did review this case with Dr. Ahmad Toha together for the discussion session during his visit to HRPZ. So this case was finalized as diffuse large B-cell lymphoma germinal center subtype. So I didn't mention about the other markers. So this is a case of primary thyroid lymphoma, which is uncommon entity, and it constitutes about 5% of thyroid malignancy. It occurs in less than 3% of all non-Hodgkin extranodal lymphoma. And it is, by definition, it should be the lymphoma that arises from the thyroid gland, and it should exclude those that invade the thyroid gland as a consequence of either metastasis or of direct extension. And most of the primary thyroid lymphoma are of B cell. So female is predominant, like this patient is male. Okay, most patients present in the 7th decade of life. The average age is about 67 years with a rapidly enlarging neck mass. The pre-existing factor is Hashimoto thyroiditis, as mentioned by Dr. Mukarramah just now, and it has been reported that the risk of primary thyroid lymphoma among patients with the Hashimoto thyroiditis is about 40 times greater compared to the general population, and it was stated that it takes a long time, about 20 to 30 years, to develop primary thyroid lymphoma after the onset of lymphocytic thyroiditis. And the lesion usually is rapidly growing within 1 to 3 months. Painless thyroid enlargement can either be in the form of goiter or discrete nodule, which is the most common clinical presentation. And pressure symptoms or compressive symptoms are oftenly present, like in this case. So usually there is associated circulating antibodies to thyroid peroxidase are positive in about 60% of patients. However, in our patient, there was no documented thyroid peroxidase taken, and reported that FNAC shows inconsistent results in the diagnosis of primary thyroid lymphoma. The rates of achieving a positive diagnosis range very wide. Is range from 25 up to 90% depending on the cellularity. So in this case, PTL should be strongly considered when the aspirated specimen predominantly consists of lymphocytes. Okay, so I proceed to the next case, case number 3. There is a 46 years old female presented with neck swelling for 2 years duration. Clinically, the left thyroid mass measuring 4 by 3 cm and soft. Clinical diagnosis during that time is multinodular goiter. However, this case, they have a prior ultrasound before the FNAC, which also shows features of multinodular goiter. So they proceed with FNAC of the left thyroid. So this is the higher power of these smears, shows that some thick fragments of tissue fragments with a bloody background, and you can see that at the edges is the you can see follicular cells at the edges. Some are forming 3D or microfollicular structures you can appreciate under low power. Difficult to comment on the colloid. I think doesn't look like typical colloid, but it's more of hemorrhagic in the background. Okay, so we close up view to the cluster. You can see that this is the macro follicular pattern of the follicular cells, more on enlarged sheets, and here is a bit more of honeycomb appearance. Okay, here a bit dispersed. However, there's no cytoplasmic flare that we can see. Okay, hardly any inflammatory cells present in the background. Possible one or two here, neutrophils. Okay, this is the other view. It shows some areas of crowding follicular cells, but the rest is more of in follicular cell, more of arrangement in honeycomb sheets. Here is some micro follicle. Okay, this is also other micro follicles. Okay, this is the other view, more or less like a honeycomb sheets or structures of the follicular cells. The follicular cells quite uniform, but in areas you can see the cell shows follicular cells crowding. Here is micro follicle, and here is the macro follicles fragments. Okay, this one is could be overlapping or crowded overlapping follicular cells. This is the other edges of the smears. You can see that the cells shows microfollicular structures as well. Okay, here is microfollicles. Okay, as well as singly dispersed in the background. Hardly any colloid, or probably a presence of thin colloid, but I cannot really appreciate in the smears. This is the close-up, the higher power of the clusters just now, just to show you the microfollicles clusters. Okay, this is also the other microfollicular structures. Close-up view, very nice microfollicle. This is the PET, shows a honeycomb sheets of follicular cells. This is also this quite dispersed follicular cells, looks like benign, not much of anisonucleocytosis, and the chromatin is a bit, it's not really open, it's more of normal looking thyroid follicles. Okay, this is another sheets of follicular cells. You can see that there is mild anisonucleocytosis here, a bit variation in the size, and a bit mild nuclear enlargement. Hardly we can see any grooving or inclusion, but here you can see that some of the cells shows open chromatin pattern. Okay, looking at the other sides, and a few cells are seen embedded in this fibrin clot. Okay, a bit overlapping and a bit overlapping clusters. You can see that there is microfollicles formation. We close up view. Okay, under higher power at that region, we can see that the cell shows enlarged nuclear enlargement with a bit open chromatin pattern, but very subtle grooving. Difficult to pick the areas with grooving, but very obvious there is nuclear enlargement, microfollicular pattern, and chromatin pattern is more open. This is the other view that shows the same features, nuclear enlargement. You can see that the chromatin is a bit speckle, fine chromatin pattern. Okay, and I think you can see that the nucleus is a bit oval rather than round. Okay, so the features is more not, I cannot say straightforward like straightforward PTC, because okay, sorry. So this is the focus up just to show you the grooving. some cells shows grooving and microfollicular structures. Okay, see the arrow is just to show you the grooving, if you can appreciate under your computer. Okay, so this is a case of example of follicular lesion of undetermined significance, or atypia of undetermined significance, because of the presence of both architectural and cytology atypia. The architecture in this case is more or less 50-50, mix up of macro follicles as well as micro follicular pattern. And the cytology atypia shows nuclear enlargement. The cells become oval with occasional nuclear grooving, and the colloid and inflammatory cells are lacking in the background. So therefore we reported as FLAS this case. So the final HPE came out this. So the resection shows the nodule is here and the adjacent normal follicle is here. Okay, so it's really nice microfollicular pattern. I highlight the cells under here. You can see very nice microfollicle, and the cells shows nuclear enlargement and a bit fine chromatin pattern. This most of the cell shows nuclear irregularity like here, but hardly we can see any intranuclear inclusion. This is the close-up view. So this case was
no, it hurt.
No, initially it came out a libum wrong.
Later I changed it.
okay. This case was diagnosed as papillary thyroid carcinoma follicular variant. So this area is a bit different because it's more of solid as compared to the other side just now, more of microfollicle. But you can see, you can appreciate the nuclear irregularity, nuclear grooving, and some of the cells shows nuclear clearing. However, we hardly see any intranuclear inclusion. So the morphology is more of the same like in the cytology smear just now. We hardly see any inclusion, pseudo inclusion in this case. So a bit about FLAS, I think it's already mentioned very extensively by Dr. Mukarramah, so I just cut it short. So basically FLAS is diagnosis by exclusion, where you need to really definite, is it benign, is it malignant? If they're not really benign, they're not really malignant, then you put under FLAS. That's a very simple way of explanation. Okay, so just to share you regarding the malignancy risk and of this FLAS, I think already mentioned by Dr. Mukarramah in the Bethesda, but this case is a study. This study is from Korea. They study a case of they review the case of FLAS from 2011 to 2014, 687 from 6,365 cases of total FNA. So they identified that 687 was reported as indeterminate. So out of this, some of the cases they repeat FNAC and also reported as FLAS, and some of these they correlate with the surgical resection, histologically confirmed nodules. So basically, the data is really correlate with the usual reported in the literature, whereby most of the nodules of resected FLAS cases is about 50% were found to be benign, and about 19% were found to be follicular, found to be malignancy. And they correlate that there is strong correlation between the nodule that malignant. There is well correlated with the unfavorable features of the ultrasound. So basically, the finding of the malignant FLAS nodule, there is a hypogenicity in the ultrasound features. So I think this is very significant for us because we usually don't have ultrasound report before the FNAC was performed. So this is really significant for us to get the ultrasound finding as well. And the other study from New York. So they study, they identify the predictive value of cytology atypia in the cases of FLAS. So this is a quite old study, but I think it's quite significant for us as a histopathologist to mention. It's 2011 published. However, they study about they review the case of 1,000 surgical patient, and they identify about 466 cases were indeterminate FNAC. So they correlate that the nuclear atypia that mentioned on FNAC mentioned conferred a risk of malignancy of about 42%. So what are the descriptors that they identify? So the most significant descriptors that they mention in their study is nuclear grooving and inclusion. Those together confer a risk of malignancy about 79.3% with specificity of 98%, and false positive rate is less than 2%, 1.8%. So it's very significant for us to mention the presence of this nuclear grooving and nuclear inclusion in the case that we subtle, meaning that we're not sure benign but not straightforward malignant. Okay, but the rest of the criteria, descriptor like samoma body or nuclear clearing and large nuclei, oval nuclei is not really significant. Okay, so basically in their study they identified that the follicular variant of PTC is the second common. Okay, that's all. Thank you very much. Okay.
Thank you very much, Yati. Those cases were indeed
Alright.
very interesting.
Okay.
I think Dr. Norizal has a few comments and a few questions to ask you.
Okay.
Okay, let's look at the chat box. First of all, I think regarding the first case, the histology tumor cells in the thyroid is not positive for TTF1, thyroglobulin, and CK19. Did you do any immunos for the first case?
First case is adenoid cystic, right?
Yeah.
Yes, adenoid cystic. Yes, they proceed with extensive immunohisto. Thyroglobulin is negative. The tumor cells positive towards CD117, focally positive to CD56, and positive for CK19. Thyroglobulin marker is negative.
Oh, TTF1 was positive, was it, Yati?
Sorry, TTF1 was negative.
Thyroglobulin pun negative.
Yes.
CK19 positive, okay.
Yes, CK19 and CD117 is extensive negative. So the slide is actually quite old, the slide. So I didn't take the picture because the ISC a bit fainted already.
Okay. I mean, you only had one GEMSA slide, didn't you? I mean, for the
Yes.
cytology studies.
For cytology, only that one slide. No PEP, no material in the PEP. Okay.
Oh, okay. But I think your GEMSA stain was wonderful. It looked like, you know, the highline globes looked like sekejap nampak macam buah rambutan, sekejap nampak macam jelly, kejap nampak macam onde-onde pun ada. Obviously, I'm quite hungry. And okay, Norizal also put another comment here. According to the Bethesda system for thyroid cytopathology reporting, the rate of AUS or FLAS should be less than 7% of all reported thyroid FNA biopsies within the laboratory, but practices vary in rates of AUS FLAS.
Yes,
From anything from 1% to 25%.
Yes.
Do you monitor your AUS FLAS rate?
Kita monitor. Yes, we monitor our rate. I think it's more or less about 10 to 13%.
10 to?
But 10 to 13%.
Right.
In our center. But basically, I read the literature. The data is varies depending on the center. So we should state our own lah. Even though the national is stated that less than 7%.
I guess even for myself, before I put anything atypia of uncertain significance, sometimes, you know, saya takut. I'm the one who is of undetermined decision sebenarnya sometimes. So it just sometimes it's just not easy because a lot of things are not available. Sometimes the sample is not the greatest. It's always the low cellularity ones or the ones with a lot of blood, no cell block, and and worst of all, no ultrasound, no radiology.